Broadcast is now starting. All attendees are in listen-only mode.
Hello and welcome to Allied Universal's webinar, Reducing Violence in Healthcare. I'm your moderator, Kelly Ellsworth. Today's webinar will last about an hour. You will see the Q&A dropdown located in the toolbar on the right side of your screen. Please feel free to ask our presenters questions at any time. We will compile those questions and we'll answer them for you at the end of our session. Today's webinar is the first in a series of sessions on this topic that we will be hosting this year and is designed as a high-level overview. Please be sure to keep an eye out for upcoming sessions where we'll be diving deeper into some of the information we're sharing today. Our presenters today include Lisa Terry and Mike Dunning. Lisa Terry is the Vice President of Vertical Markets at Allied Universal. Prior to her current position, she served as Director of Hospital Police and Transportation at the University of North Carolina in Chapel Hill, and has also served as the Chief of Police and Public Safety for both WakeMed Hospitals and the Eastern Virginia Medical School. As a former president and an active member of IAHSS, and as the current Senior Regional Vice President of ASIS International, Lisa has been fortunate enough to collaborate with some of the country's greatest minds in healthcare, security, and policing. She shares her knowledge and strategies and lessons learned for successfully preventing and mitigating violence in her books, Preventing Violence in the Emergency Department, and the Active Shooter Response Toolkit for Healthcare Workers. Our second presenter, Mike Dunning, is the Senior Director of Healthcare Operations. Mike is responsible for the oversight of all Allied Universal healthcare account operations, to include serving as the subject matter expert for our internal and external clients. As a published author and recognized expert in this field, Mike aids in the development of security programs and provides counsel for both our internal and external clients to ensure security programs and objectives are developed, implemented, and adhered to. Mike's experience includes over 20 years of management in the security field, with over 14 years specific to healthcare. Prior to his current role, Mike served as a Director of Security and Emergency Management for 2 healthcare systems, which included inner-city Level 1 trauma centers. Mike has also served in the U.S. Air Force in a variety of security and executive protection roles. He also holds multiple board certifications in security and emergency management, along with a bachelor's in criminal psychology and a master's in emergency management. He is an active member and has served in multiple volunteer positions with associations including IAHSS, the American College of Healthcare Executives, ASIS, the Veterans of Foreign War, and more. I'll now turn the presentation over to Lisa Terry.
Thank you, Kelly. In order for us to actually discuss reducing violence in our healthcare environment, we must first acknowledge the core concept that violence is the precursor to violence. Understanding, capturing, and communicating violence and the escalation of violence is paramount. Non-physical forms of violence often, and most often, lead to physical violence. So before I start some of our presentation and share some statistics, I wanted to share with you the definitions on which they're based. The first one is from the CDC, and they define workplace violence as violent acts, including physical assaults and threats of assaults directed toward persons at work or on duty. And OSHA, who also defines workplace violence as an action, verbal, written, or physical aggression, which is intended to control or cause, or is capable of causing death or serious bodily injury to oneself or others, or damage to property. Now, these statistics I'm going to share with you are probably not too surprising. Workers in healthcare settings have a 20% higher chance of being victims. 12% of the emergency department nurses have experienced physical violence. 59% experienced verbal abuse during a 7-day period. 21% of RNs and nursing students reported being physically assaulted over a 12-month period. And over 50% reported being verbally abused over 12 months, and healthcare accounts for nearly as many injuries as all other industries combined. And to me, this last one is the one that is so significant. 75% of aggravated assaults and 93% of all assaults against healthcare workers are from patients or customers. So acts of violence are most often, as we those of us that have worked in it for a long time know they're underreported. Only 30% of nurses actually report incidents of violence. So in 2017, the American Hospital Association actually released a study that they conducted over the year of 2016 that revealed hospitals and healthcare systems alone in the United States expended $2.7 billion responding to violence. And this actually got a lot of attention to the hospital executives and accreditation organizations. And things really, other research started to happen after that point. In 2017, FEMA, a lot of other organizations started looking at some of those fatalities. There were 48 healthcare worker fatalities in 2017 that were due to violence, 31 due to homicides compared to 458 in all industries. 6 of those were domestic partner, 5 co-worker or work associate, 6 inmates, 14 others, patients and visitors. 22 of those were from gunshot wounds. Some were from blunt force trauma. 16 suicides. So really started to compile a lot of that data. Of course, the primary motivators: revenge, anger, fanatical ideologies, severe and untreated mental illnesses, and of course the desire to be famous or infamous. These are things that we know about. These are your primary motivators for that violence. But we also have contributing factors: the poor lighting, restricting vision in corridors, rooms, parking lots, especially parking lots, parking garages, no access to emergency communication, no panic alarms, duress alarms, cell phones won't work, there's no call bells, unrestricted public access 24/7, stressful conditions, long wait lines, bad news being related and no real good places to give bad news, staff working in isolation. However, there's always those contributing factors. Parking areas, as I said, they're dark and unwelcoming. Is anyone paying attention to those areas? Is anyone out there looking for escalating behaviors? Are they trained to be looking for escalating behaviors? There's a lack of organization policies for security and for staff. Domestic disputes among patients and visitors. We have firearms that come in, and there's probably a large number that we don't even know about. There's either inadequate security or a perception of inadequate security, and there's inadequate mental health personnel on site. Understaffing, especially during meal times and visiting hours. And then the culture challenges. The culture of the staff, the patient, and the visitors can either be a limiter or it can be a force multiplier. Is there a positive team atmosphere, or does negativity breed negativity? Is there a perception of safety or not? Compliance challenges. There are always compliance challenges. We've got to balance the rights of the patient to receive care in a safe setting with that of the employee to work in a safe environment. We have a responsibility to protect the most vulnerable. We have to protect everyone's emotional health as well as their physical health. Physical restraints, annual competencies have to be met. We've got to have training for all concerned, and it better be in writing. Are your officers armed? You have to ensure that you have processes to meet CMS. Every time there's an incident, you better have a panel review. Avoid using any type of spray in a hospital setting due to your HVAC. Maybe only foam or gel if you use any type of spray. Make sure that you've got written policies and an ongoing use of force review, your policies and protocols. And then your violence management program. Healthcare workers are more likely to take time off after experiencing acute and chronic episodes of violence in the workplace. Workplace violence in healthcare causes high turnover. Violence results in low staff morale and lawsuits. Research has shown that these three statements are actually true. So it begins our journey in evaluating an actual return on investment of having a robust violence management program. If nothing else, these three statements, which have been found to be true, that's your ROI. Again, without a program and processes, there's no defined training, there's no specialized reporting. Naturally, there will be a lack of proper response and often a delayed response, which brings us to that reactive state in which we continually find ourselves. We react. The solution is going to require a change in our mindset. We should consider getting away from this reactive only. We should prepare, respond, and recover. The Joint Commission, in concert with the American Hospital Association, launched an initiative a couple of years ago to have hospitals take a proactive stand against violence. No more violence to healthcare workers. Essentially, teach them that non-physical forms of violence is the precursor to all violence. Start with that initial behavior of concern. So this entire webinar is to talk about build a proactive violence management program. And we're going to talk about three main things. How do you build that proactive program? The first way is to establish a threat assessment team. Build a training program and develop the plan, policies, and procedures. The first facet, the healthcare threat assessment team. So we would ask that you establish a process, a multidisciplinary team that would identify, assess, validate, mitigate, and respond to any threats of violence or any other behaviors of concern. Now, obviously, developing and maintaining a threat management program and a threat management team is a separate, much more in-depth webinar that we will be offering later this year. So I'm not going to go in depth, but I am going to give you the 4 overarching objectives for this threat assessment team. The first one is focus on protecting the patients, staff, and visitors. The second objective is proactively identify potential threats or acts of violence. Establish proactive steps to prevent violence and ensure clear paths of reporting and communication, very high level. The guiding principles of that team, and if you've not ever heard of Gene Geisinger and the Handbook for Campus Threat Assessment and Management Teams, I wanted to definitely mention that. Dr. Geisinger wrote the book, and I did want to share his 12 principles for that team. If you do not have a team, this is the book. If you put one together, if you already have a team and you've never used this book, I want to recommend it. So I'm going to tell you those 12 principles. His first principle is that targeted violence can often be prevented. Violence is a dynamic process. Targeted violence is a function of several factors. Corroboration is critical. You identify it and then you verify it. You do not just go off without verifying that what's been told to you is actually factual. Threat assessment is about behaviors, not profiles. Cooperating systems are critical. Does the person pose a threat? Keep the victims top of mind. early intervention and identification, multiple reporting mechanisms, so that it can be at any level of the organization that can be reported, multifaceted resources, and safety is always the primary focus. Again, this is in the handbook for campus threat assessment and management teams. Cannot push that book enough. It's wonderful. The other thing that is very essential for this team is that they have a threat assessment tool. There's a lot of great ones out there so that you can actually assist with analyzing and deciding on your next steps as you get information that comes into the standing team. There are good ones out there. Some hospitals have actually put together their own. This is an example of a partial tool that one hospital actually put together that really helped them understand and really know the next steps, as well as to analyze that data. And we have a poll question.
Okay, thanks, Lisa. So I'm going to launch our first poll. Do you have a standing threat assessment team in your facility? You can just take a few seconds to answer yes or no, and then we'll share out the responses. Go ahead and close it out in about 5 seconds. Okay, so we came in exactly even, 50% yes, 50% no.
Wow, thank you very much. Great information. I think, again, highly recommend that if you have one and you've not utilized that book, I would really push that. We will be putting together a webinar where we will do a deep dive in putting together that threat assessment team, as well as a threat management program later. It's not something that we can talk a whole lot about right now, but look forward to doing that. So the second facet, obviously, of a proactive violence management program is to build your training program. It's essential that training occur often and is continuous. You see that it's continuous, just the whole circle. To me, the most important part of this circle is the recognition portion. You've always got to look for those acts of aggression and behaviors of concern. That's constant. If you do not get it at that point, then you miss the whole thing. The healthcare facility also should have training programs that address, again, the prevention, recognition, response, and reporting of those threats, the acts of aggression, and other behaviors of concern, and education appropriate for the job function and potential risk should be provided to all healthcare workers and support staff. So your training program should obviously identify potential issues and early awareness. It should adhere to whatever your reporting protocols are. You should be able to activate an emergency response. Regardless of this standing threat assessment team, there should always be a way to have an emergency response team that could get in there and handle that situation. Document threats and incidents. Emphasize that all threats should be taken seriously. Never minimize a threat. Share learning and key findings from historical issues. And then continuously train on plans, policies, and procedures. You never arrive. Training is always continuous. There's always learning. The third facet of the violence management program is to develop your plans, your policies, and procedures. And Mike will go much more in depth in talking about that. But one resource that I use and I highly recommend when developing policies and plans is the IAHSS industry guidelines. I've listed here some of those guidelines specific to violence, the violence, healthcare, targeted violence, management of weapons, threat management, de-escalation training, and violent patient visitor management. These guidelines really assist in putting together your policies and your plans. Other resources, obviously OSHA, the HR 1309 is still in proposal. The California Health and Safety Code, that's listed there, two great things. Obviously, the Joint Commission Sentinel Event Alert, number 59, the Emergency Nurses Association Workplace Violence Toolkit, and then there's myriad of others out there that are really good, but just look for those resources. And I'll turn it over to Mike now.
Thank you, Lisa. Good afternoon, everyone. So before we really dig into this, I want to talk about changing the mindset a little bit more and do a small comparison. Over the last 20 years, we've had an increasing proactive approach to reducing fires. Think about all the things that we have to do in our healthcare facilities to make sure we don't have fires and make sure those fires don't spread. As a result of that, in 2017, there were only 1,100 fires in hospitals in the United States. Those resulted in 5 deaths, 25 injuries, and about $25 million in damage. At the same time period, 2017, there were over 13,000 reported injuries to healthcare workers due to violence. Those injuries resulted in 48 deaths, 31 of which were ruled homicides. So thinking proactively when we're looking at workplace violence is as we do in fire prevention. We're putting layers in place to help reduce the damage or the chance that workplace violence could happen. And so we're going to start looking at these layers here as you see on your screen. When we're talking about detection, we're talking about detecting behaviors that lead to violence and other risk factors. What are we doing as far as reporting and analyzing incidents that have occurred in the past? Do you have staff that have restraint orders on people? Do you emphasize the see something, say something rule? Do you have cameras that have analytics? Are you using technology? Let me give you just a quick example of how detection doesn't work. So in one of our hospitals, we had a registrar, and she had a mobile computer workstation where she was going to go into a patient's room and register that patient. Well, this person had earbuds in and was listening to music, had no situational awareness going on in any way, shape, or form. She walked into the room and was hit by a chair that was flying through the air. There was a domestic disturbance going on in that room, and she had no awareness of what she was walking into. So being able to detect what's going on around you is very important. Then we're going to talk about deterring and the things that we can use to deter these activities, how we delay those activities from increasing or escalating, how we respond to, and then how we can recover from them. Next slide, please. Okay, so let's talk about detection. And this is all about knowing about your surroundings, situational awareness. And I'm not just talking about for security, I mean for everyone. Everyone needs to know that you have that great big fish that you just caught, but you don't see that big grizzly bear coming up behind you. That could be a problem. This is also where technology can be used to help you with detecting and knowing what's going on around you and what's going on or could go on in your facility. So we're talking about camera systems with analytics. We're talking about camera systems that have license plate recognition or facial recognition. There are even systems out there that can let you know when a certain cell phone number has entered into your facility. And if you know who owns that cell phone because you've had contact with them before, you know that that person has had a history of violence. And as was said at the very beginning of this, we know that violence begets violence. So if there's a history of violence, we can kind of predict that there could be more violence to come. Next slide, please. So when we're looking at the security side of this, this is again where you can put more technology to work. Are you actively screening who's coming into your hospital? Are you actively screening who's gaining access to your properties? Do you know what's going on around you outside of your properties? There's technologies and resources out there that can help you identify risks to your facility before it gets to your facility. One thing that comes to mind is the riots that occurred in Baltimore. One of our facilities was using some technology, and they were aware that those riots were happening before they reached their hospital, and they were able to do things to make sure their hospital was safe. There are also notification and alert systems out there that you can use to make sure that if you do spot something, if something is coming to your awareness, that you can get that information out and make sure people are aware of it. Next slide, please. So when we talk about deterring, again, we're going to talk in two factions, everyone and security. When we talk about deterring events from occurring, we're talking about an active presence. And what I mean by that, and a lot of you understand this in the realm of customer service. So when you see someone walking around and they look lost, well, the chances are they're lost. So what do we teach folks? Go up and engage them. Ask them what they're doing. Can we help you with something? Well, that does two things. One, it increases your HCAP scores and it makes people understand that you're a friendlier location. But the other thing it does is it puts people on notice that people at your facility are paying attention to their surroundings. They know what's going on. So if they were coming in there for not so good reasons, they would now be aware that, hey, you know what, these folks pay attention and they understand what's going on. Another active presence when we get into moving into the de-escalation is that you'll be able to start to see things that, hey, that doesn't look right, or you know what, that person's talking a little too loud, or that person's using language that tells me that they're escalating. So that helps us go into a service recovery mode, or goes into a mode where we can de-escalate that situation. One thing to remember here is that we're all on camera, or look at it that way, that we're all on camera, because there are patients around you, there are visitors around you who is witnessing all of our interactions and everything that we're doing. So as we're deterring, they're paying attention and listening to how we're doing that as well. And that could be positive or negative depending upon how we interact with that person. One thing I want to touch on here on this slide is that we know that the amount of violence that goes on in hospitals is very underreported. And the advisory came out with some information not too long ago about why these incidents are being underreported. And first off, it's not easy for people to report. It's either looked down upon to report violence, or we just don't have an easy mechanism for someone to say, hey, this happened and I want to report it. The second, and I think probably the most important reason why we have underreporting, is that when someone does report something, there's no perceived action taken once the report is given. So if I'm reporting something and nothing happens, why should I report it? It's that perception. So people need to understand that something is going to happen and that you are going to take proactive measures against it. Can you go to the next slide, please? Again, how are we an active presence when we start talking to security? How do your security staff look? How are they perceived? How do they interact with other people? What tools do they have at their disposal? So when we talk about tools and weapons, understand that there is a pro and con to everything out there. If for those of you that have firearms, you know, a firearm, will that deter a shooter? Sure, it could deter shooters, but it's not going to deter a jerk. A jerk is a jerk, and they know you're not going to use a firearm against them because they're being a jerk. So think about the tools and don't rely too heavily on one. Again, think in layers. For those of you out there that are using magnetometers, do they deter weapons? Yeah, absolutely. They can deter weapons that are being brought in. But the other thing that they can do, if they're not implemented properly, is people will watch. How are you using those metal detectors? Are you scanning everyone, or are you letting certain people slide? Are there other ways to get into your facility that can bypass those magnetometers? Where are they and how easy are they to get into? So when you start using these tools and these weapons, think more in line of why are you using them? What are you using them for? And what are your expected outcomes for them? Next slide, I believe it's a poll question.
Thanks, Mike. So our next poll, does your facility utilize a standalone magnetometer to screen people entering your emergency department? If you can answer yes or no. And we'll just give everybody just about 10 more seconds.
Okay, 90% is a no. Not so surprising. They're not used in a lot of locations. There's a lot of limitations to the standard magnetometers out there. You can't put them in door frames because the door frames are metal. You have problems with the rebar that's in the cement or in the concrete flooring. There are newer devices out there that aren't as limited, that can be done or can be used in smaller spaces. So if you're interested in magnetometers and looking for those, we'd be happy to help you. It's not something that we sell, but it is something that we have seen that works very well. If we can go to the next slide, please. All right, now let's start talking about some basics, and I'm not going to go over each one of these. I'm going to hit a couple of things that are just kind of top of mind. When you're looking at your exterior, your parking areas, I want you to think of it this way. This is your first impression of someone walking into your home. Now, when you invite someone to your house, what's the first impression? The moment they walk through the door? No, it's the moment they pull into your driveway. They see your yard, they see your grass. Is it well manicured? Is it well kept? Or do you have weeds that are, waist high and they're going to have to use a machete to get through to get to your front door? Perception about your facility starts the moment they turn onto your property. So do you have highly visible signage that directs people to the right location? Are your parking areas well lit? Do they create an atmosphere of, at least positive or enlightened atmosphere, or are they foreboding and no one wants to enter it? There's a huge correlation between someone parking into a dark, foreboding parking area and their immediate impression and the imprint on their psyche about the depressed mindset that going into your facility. So think of it on different levels. Not only do you want to keep your parking areas and parking garages well lit for safety and security reasons, but you also want to keep them well lit because you want people a little more positive coming in than scared to death when they walk into your parking areas. Another thing on this slide is about security teams being visible, making sure that they are they're present, that they're seen, and that presence, again, going back to that physical presence, is a positive. It's a deterrence, that they're welcoming, but in the same sense, they are seen as security and that they're very proactive. Okay, next slide, please. Going into access control, there was an article today in Modern Healthcare about a person who was posing as a physician, and he was in and out of several hospitals for several weeks. And it took a long time for them to catch that person. I want you to think about what the optics are and what the backlash of that would be once this hits the news and identifies your hospital as having someone pretending to be a doctor roaming through your hospital. So access control is very important, not only in making sure that the right people are getting in, but that the wrong people are staying out. Next slide, please. When we're talking about our reception and waiting areas, it's key to not forget about those people working in those areas. You want to make sure that you're training your receptionists and your those folks that are at those front desks of all those departments, that they're trained in how to recognize signs of escalation, how they can be aware of their surroundings and keep their head up. They have to know who to, because they're on the front line, they have to know who's escalating, and the second part of that is, what do they do about it? So if they see someone who's escalating, they see someone who's getting out of control, they just don't watch it happen. They have a number to call or a button to push or some way to get in touch with someone. They should also be trained in your procedures for if you have to evacuate or what you would do for an active assailant or an active shooter. And if you're using run, hide, fight, or some other, don't forget about those folks, because they're key as well. They're the first ones that are going to see it. Next slide, please. Okay, patient care, patient treatment areas. Again, it follows the same pattern. Access control. Are the staff trained to recognize signs of that escalating behavior in patients, but also in visitors. So again, it's kind of the same theme that you want to keep throughout your entire facility. When you conduct drills, a lot of facilities and a lot of our clients, they ask the question, well, we need to do an active shooter drill and we need to do one every year. I'm like, okay, great. That's a great thing to do, but it's not something that you do just at the snap of a finger. You need to escalate that, and we'll talk more about that later. And you need to think about what if scenarios. Some of the best training you can do is when you walk into a department, start asking some what if scenarios and let people start thinking about it before they actually have to respond to it. That helps build muscle memory and helps you identify weak points of where training is. Next slide. Again, we go into administrative, billing, HR areas. Couple of things here, especially on the HR side of it. It's a best practice and it's a really good idea to let security know when you're going to term someone. I hear a lot of HR people say, well, you know, we know the folks and we'll call security if we feel they're going to escalate or if we feel there is a danger. And here's my challenge to that. You don't know anybody really. And when you are about to change their ability to bring home a paycheck, you don't know what they're going to do. So you want to make sure that you communicate with security whenever you have a termination. That doesn't mean security needs to be in the room with them, but it does mean that this could happen. Now, the last one here is security reviews assessments, and that these assessments are conducted regularly. You should be looking at your security program on an annual basis, and not just to the level that meets Joint Commission standards, but do a thorough look at your security program because things change. Things change sometimes very dramatically. Do you still need a camera at a certain location, or maybe you need one at another location? What construction has occurred? What new walls are up? What new routes of travel are there? What new parking lot changes are there? So do a deeper dive in your security program on an annual basis just to make sure you're still doing what you need to be doing. And next slide, I think that is a polling question.
Yes, our next question, does your facility actively use an electronic visitor management system to screen visitors entering their property? You can just answer yes or no. Okay, we're going to go ahead and close it out here in a couple seconds. Okay, so we had 30% yes and 70% no.
Okay, again, not surprising. That goes back to who's coming into your facility. How do you know they're coming in? How do you know they're leaving? How do you know where they're going? For those of you that have pediatric units or infants that are in your facility, how do you know those folks are not the folks that we don't want in our pediatric units? How are we safeguarding those people, those children from those people we want to safeguard them from? So think about those management systems and how you screen folks coming in. There are many out there on the market. There are some that do a really fantastic job and they're easy to use and they're not that expensive. You can check them against sex offender registries. You can check some criminal background checks on them if that's what you need to do or you feel you need to do for your facility. But using some type of management system can help you screen out folks. Next slide, please. Okay, so let's talk about security and some things that we've seen not only in training, but in that mindset for security that we might want to take a closer look at. One of the things is that we teach our folks to conduct your security patrols at random, and we've heard this for years, random. And to me, I'm just gonna call it out, that's wrong. And here's why it's wrong. The back 40 parking lot that is completely empty at midnight does not hold the same priority as the emergency department. But if you just tell your officers, conduct your patrols at random, you're going to get just as many patrols in your emergency department as you do that back 40 parking lot. So what I challenge is, when you teach officers about conducting things at random, which we do, but we want to give more priority to those areas that we need to focus on, those areas that we've seen more problems or that are a higher risk for violence, like your emergency department, your intensive care units, your critical care units, your mother-baby units, your behavioral health units, for example. Something else we've also seen is that security spends a lot of time doing non-security stuff. And we all understand that we all wear multiple hats in hospitals and that we all need to chip in and do things. But we need to keep in mind that security needs to be doing security, and anything else we add to it is going to take away from their ability to deter and detect things that are coming into your facility that can cause a danger. Next slide, please. Some of the things that we see that are best practices: formal check-ins on each unit. So security, when they're conducting their rounds, they don't just walk through a unit. They walk through that unit with a purpose, and they talk to the folks on the unit and they check in. They target those hot spots where they talk to the nurse manager, they talk to the nurses or the receptionists, and they say, hey, this person in this room is kind of escalating to giving us a problem. And we now know that so that we can increase our rounding on that unit. And then we have a formal handoff between security shift change, and we pass that information along so that we're not relearning everything every shift. We should be passing that information along just like nurses do when they change shifts and they talk about the patients. Next slide, please. Now we're talking about delay. This is more about delaying someone who wants to cause harm and delaying them from getting into the facility or getting into certain areas, things that we can do. Next slide, please. So if you look at some of the slides, we're talking about barricades, we're talking about bollards in the front, we're talking about things that are aesthetically pleasing, but would prevent someone from hopping over a counter and getting into a treatment area or getting into an area where they could harm someone. Just a quick side note, we had someone not too long ago set himself on fire, get into his vehicle, set himself on fire, and drove right into the front entrance of the hospital. That could have been stopped if they had had bollards or, you know, those nice, big, heavy concrete potted plants in the front of their hospital that would prevent that from happening. That middle picture where you see a patient's room, when you look at that, look at it from the eye of security. Look at all those things in that room that could pose or be used as a weapon against someone. Now, I'm not saying we have to get rid of them. At times we do, depending upon the patient that's going in there. But I also want you to look at the space. Where is the caregiver in that picture? Where does that caregiver stand? And if the bed is between the caregiver and the exit, then you're going to have a problem. Don't let your caregiver get trapped into a room. If you can, reconfigure your rooms or the setup of the room so that your caregiver can escape easily out of that room. Use the space as an advantage, not as a trap for those caregivers. Next one, please. Here's just a quick diagram of what you could also use a patient's room for. So in those active shooter type of scenarios, you know, if you can't evacuate that patient, maybe you can get the patient in the bathroom, block it with the bed. This schematic actually comes from a plan of one of our hospitals where they teach this and they implement this during their drills to help with that response. Next, and I think it's a poll question.
Yes, this is our last poll question. Has your department identified safe areas for staff to utilize in the event of an emergency? If you could just answer yes or no, please. We'll just give everybody just a few more seconds. Okay, so we had 61% who answered yes and 39% no.
Okay, great. The only thing I would comment here is for those of you that have identified safe areas, make sure that your staff are trained that those are safe areas, and most safe areas, to be a safe area, you should have the ability to lock or barricade the door. The door should not have a window so that someone could peek in, and there should be a hardline telephone in that room so they could call out. Don't rely on people to have their cell phones with them at all times, because I guarantee you when you need it, that's the time your cell phone's going to be in your pocket of your jacket that's hanging on a chair, or the battery's dead. So try to make sure that there's a hardline phone in those rooms. Now, for the sake of time, we're going to kind of move a little faster here on the next slide. When we talk about response, the biggest thing to remember on response is not only do you have to teach your security and your clinical staff how to respond to things, but teach folks what they should expect from security. What should be the expected response when someone does respond? When you do have certain incidents, what's everyone's role? There's a lot of anxiety when we start talking about active shooter or active assailants or responding to violence, and they don't know what they don't know. So if you can not only teach them what is expected of them, but what everyone else on the team is going to be doing, and that way it really promotes that team effort, that team response. Next slide. Again, going to that team response, if you're going to be looking at having responses to violent incidences, you should have that plan in place before the incident occurs. Have a designated team who's going to respond, what their roles are, who's going to do what, who's going to lead it, who's going to say that is over, that's done. So in your violence and your situational response, make sure that you go through the process that you have. The last bit of that process, though, that 15-minute debrief, is extremely important, but we'll talk about it here in the next couple of slides. Next slide, please. When we start talking about active shooter or assailant drills, these can become very complicated. I will tell you from personal experience, it will take you 6 to 9 months to plan a true drill. This will be another webinar at a later date, and we will go through from start to finish on how you conduct a drill for active shooter. Again, 6 to 9, sometimes even 12 months, depending upon the size of your facility, in order to do it correctly without a lot of people getting hurt. Next slide. So when I said about that 15-minute debrief, it doesn't have to be 15 minutes, but here's what we have found to be very helpful in reducing the amount of times not only do we have to respond, but how many times we put people in restraints. These are questions that should be asked at that debrief. After every time you go hands-on with a patient, you should have a debrief. The first question is everyone okay? That does a couple of things. First, it lets everyone know that you are concerned about them. Second, it quickly identifies anyone who's injured so that we can take care of those injuries and do the reporting that we need to do for a worker who's been injured. The second question, did we respond appropriately? And everyone needs to be able to have a voice in this debrief to say, you know what, I thought we were supposed to respond this way, but you responded that way. Was I wrong? Is there training here that is needed or clarification? The third, what was the escalation trigger point that we missed? What was going on with this patient that we missed, or maybe we saw it but we didn't see it as an escalation point? Again, this helps with teaching situational awareness and emphasizes looking for escalation. And then the last, what was the root cause of the outburst? We had a very unfortunate incident occur several years ago. The result was that a patient died from an event, and when it all came down to it, the root cause of the outburst was the patient wanted ice. They'd been asking for a cup of ice for several hours, which escalated to the point where it became very violent. So you might be a little surprised when you start looking at root causes of outbursts. Next slide, please. Recovery, I need you to understand this. If you have a criminal event at your facility, especially some type of active assailant or active shooter, you will have a crime scene. That crime scene will stop the operation of the area in which that crime scene is in. You need to have a plan on how you're going to provide ongoing care, how you're going to have business continuity. So have those plans in concert with your response plans, because the recovery period is often much longer than the actual response period. Okay. Also in the recovery phase, I'm sorry, just one more thing. Always make sure that you're looking out for PTSD amongst your staff members and visitors. Even if you're doing a drill, we've had many active shooter drills where those who were involved in the drill, they knew it was a drill, we practiced on the drill, and yet when the drill actually occurred, they responded and had a very negative response to it. So make sure you've got HR involved and you're looking at things from a PTSD perspective. Well, we're looking at cultural challenges here, just a few stats. You've been looking at them on your screen. All this is telling you is that people feel safer when they know that there's a program in place and they know what that program is. Next slide. And this is talking about some results where we put these programs in place. We've seen a 35% increase in the feeling of safety by staff, 45% increase in confidence of security, 32% increase in patient satisfaction scores. Those are hard numbers that you can bring to the table as a return on investment. And with that, I think I'm going to turn it back over to Lisa.
Thank you. So just to kind of finish up here, obviously violence manifests in many ways. Treating and preventing violence does not end with workers inside the healthcare facilities. We know from a lot of research that victims and perpetrators are 44% more likely to return within 5 years with a new injury. So one of the things that the American College of Healthcare Executives put together this past year was they believe that healthcare executives now have a professional responsibility to treat and take steps to mitigate violence and advocate for cultures of safety. So they actually put together 6 recommendations that they gave to hospital executives. They want them to clearly define workplace violence, assess the scope and prevalence of violence within the facility, raise awareness that workplace violence is now considered a public health issue, identify and remediate risk factors and provide training on how to recognize and mitigate workplace violence, evaluate, measure, and report progress, which I think this is wonderful. The final recommendations from this is hopefully get the workplace violence prevention program in place, get your threat management, your threat assessment team, the whole threat management, review those contributing factors and plan for them, and provide training to all employees on how to respond to incidents. Communicate with your workers about what resources are available. Measure those results and celebrate the successes. Know that you're going to have a misstep and treat that as an opportunity to be the change. Collaborate between security and your clinical services, and I found that that's always a recipe for success. And with that, I'll turn it back over to Kelly. Thank you for your attention.
Thanks, Lisa. So we have had a few questions come in so far. Just a reminder, if you do have questions for either of our panelists, you can type them into the panel on the right side of your screen and we'll answer them for you now. Our first question, how often should a standing threat assessment team meet?
I guess I'll take that if that's okay. Really, there's no actual absolute, but many threat assessment teams, some have actually met daily for 15 minutes, Monday through Friday. Some meet weekly, some meet bi-weekly, some of them meet quarterly, monthly. Some have actually met on an ad hoc basis. I don't recommend that for a standing team. Again, I'll go more in depth at a later date because the makeup of the team and the information that comes together really, you need to meet much more often than on an ad hoc basis.
If I could just chime in on that, the team meetings should correlate very directly with what threats you're seeing. if you're seeing a lot of threats or if you're handling a very difficult case, you may want to meet on a daily basis. I've been involved in some that we met multiple times a day for the first several days. So don't look at it as you've got to meet certain times. It's going to be based off of what you've got going on. And then you do want to have a standing meeting at least quarterly, so that you know you can review what's happening and you can review what changes are taking place, and bringing all the people on the team together, so at least you communicate and make sure everyone's current on what's happening.
Okay, thank you. Who would you recommend the security director should report to?
That is a really good question. Again, it's going to be different for every facility, because it's about people and personalities and who wants to take ownership of it. But I will say this: I think a security director should report to someone who has the ability to make decisions, and we all know, what those positions are, but that they can make decisions when those decisions need to be made, and whether those need to be financial decisions or staffing types of decisions. But it needs to be someone who's high enough up that can make those decisions when they need to be made.
Okay. And Mike, could you please repeat the statistic on improving fire prevention, including the amounts of decrease in fires?
I don't have the decrease in fires in front of me, but I do know that in 2017 there were 1,100 fires in hospitals. I know that is a huge decrease in the number of fires over the last 20 years. We can get those numbers for you.
Okay, thank you. Is there a threat assessment tool that's available for use by our clients or potential clients, or is that something that they would need to create?
There is a tool that I would be happy to share with our clients, and there are some out there. There's one that's Dr. Dysinger has within that book.
Okay, and what is your opinion of a canine program as part of a violence management strategy in healthcare?
Let's see. How can I respond to this without being too enthusiastic? Those places where we've used canine, we've used them in two different settings. One where violence was through the roof. We've seen dramatic decreases in not only violence, but the use of restraints. It is a great PR tool. So the use of canine, and I'll just put it this way: if you give someone a firearm, they know you're not going to shoot them unless there's a deadly force situation. But people understand what dogs can do, and there is a perceived deterrence there with canines. I wholeheartedly support canines in healthcare situations.
Okay, we have just a couple more questions. Are security officers in a police type uniform better deterrent to reduce violence than security officers in a blazer type of uniform?
I think, I'll kind of start the answer. I think I'm all about a blended type of program. There may be a place for someone in a very soft uniform that may be the perfect response and the perfect deterrent. And there may be a need to have someone in a harder, little like a Class A type uniform. So it's very difficult to give, in my very humble opinion, an absolute answer. I think that there are situations where either and or both work very well.
I can absolutely tell you that this should be part of your discussion when you're doing your threat assessment. So utilizing exactly what Lisa said, utilizing the different uniform types can be great factors in deterring, depending upon where you use them. So yes, I agree with her.
Okay, this is our last question. This is a hospital where their staff has to park off campus and security has to transport them to and from their vehicles. Employees are constantly saying they don't feel safe in the parking lot at night. Do you have any type of suggestion that would help with that?
Sure.
Mike, I'll let you.
Yeah, sure. First, I would want to take a look at the lighting. What's causing their perception of not being safe? Are there incidents? Have there been incidents in those areas, even if there's one? And what was done to eliminate the risk of those incidents occurring? Look at lighting. Look at how things are configured. I was at one location where there was an outer parking lot like that. Lighting was, on paper, lighting was supposed to be very good, but once you got out there, trees had overgrown, vines had overgrown, the fence line was about pushed down by the bushes and shrubbery. So there's a lot of things that you can do with that crime prevention through environmental design, CPTED. There's a lot of things that you can do to help people feel safer in a certain area. Increasing patrols by security, having security present at those times when that parking lot is going to be mostly traversed, you know, at those shift change times. Those are all little things that you could do and make adjustments to make people feel safer. And then there's technology you can utilize. There's a lot of things like Light My Way. You can have certain call boxes out in those areas that have cameras that can talk to people, that can light up the area when they go to their car. So there's a big combination that you can do between lighting, security staffing, and technology.
Okay.
Exactly.
Well, thank you both for presenting. That wraps up today's webinar, and thank you to all of our attendees. We will be sending out a follow-up message later this week, which will include a copy of today's presentation as well as a recording. And keep your eyes peeled for our next upcoming healthcare webinars. Thank you, everybody. Have a great day.